Presentation. We've got Dr. Stuart Cumming to address us today, and most of you probably have heard Stuart in the seminar or in some other setting, and so you know that he's born, raised, educated, and now working in Scotland, which is hard to believe given his very, very southeastern English accent. In fact, no, it wasn't. No, we won't get onto the accent bit till later. So Stuart graduated in 1983 and soon after dedicated his time to general practice. In fact, he became a general practitioner or a GP practitioner at the Killern Health Centre in 1987 and remains here. He's still one of the 4 general practitioners in that practice. And if I've estimated this correctly, Stuart, even given your time away and your other responsibilities, that would be over 250,000 consults, probably out of the same room. Yeah, that's a lot of consults, isn't it? Stuart is also the Chief Medical Officer for Primary Care and is a board member of the Forth Valley NHS. He's in his 4th term with the board there. And that position, I think, comes as a result of you being the chair of the Community Health Partnerships Professional Committee. That's what my research tells me anyway. We know that Stuart has some interests, some main interests in his practice, which are around his clinical interests, which are around mental health, paediatrics and obstetrics. We also know, though, that there are interests beyond those specific service types. They are about the processes, about improving health processes, and you've been very active and remain so in improving various access to services, redesigning services, effective communications between clinicians and developing integrated care pathways. These are some, not all, but some key elements in developing an integrated healthcare system, for which we will hear Stuart very soon. What his biography and the internet don't tell us, though, are a few other things. And about this point I start making them up and no one can prove it otherwise, I think. But these are not made up. So Stuart's actually here because his daughter's about to get married in 2 weeks' time, if I'm not mistaken. And if you've ever had anyone get married, you know that there is a tension in the household. So this is perfect timing to be in New Zealand on the exact opposite side of the world and not have that attention around you at all. We also know that he has a couple of favourite tipples. One is the New Zealand Pinot Noir, and I think some have said you're a bit of an aficionado at this, and I'm not sure it's because you... Yes, I was just going to say, I'm not sure whether it's the amount or the ability to distinguish but he's also very, very much a single malt fan, Glengoyne, I'm told, and I'm lucky enough to have a very small bottle of that with me, just in case the presentation doesn't go well. And that might explain some of Stuart's later night sightings, because he lives on the shores or close to Loch Lomond. So I've heard him talk about Nessie at times, and I've always wondered how he got that inspiration, but that probably tells us. So I'm about now just to introduce and let Stuart loose on you for the next hour, and so it's my honour to welcome you to Dr. Stuart Cumming.
Thank you very much, Murray. Good afternoon, everybody. Kia ora. Thanks very much. Thanks very much for inviting me to be here today. It's good to be here, and I've actually really enjoyed my stay in New Zealand, and everybody's made me feel very welcome, and as you've just heard, has plied me endlessly with red wine. I also realise I've probably got a bit of a challenge speaking this afternoon. This is given it's a Friday afternoon and you've just all had lunch and you're all sitting in a dark room, so hopefully there'll be some people still awake in a wee while. As Murray said, I've spent half my time as a GP working in Scotland and the rest of the time as Associate Medical Director for Primary Care with the Forth Valley Health Board in Central Scotland. And what I was going to try to talk about mainly this afternoon are some of the ways that we've worked with professionals to make positive changes to our healthcare system and also to make quality improvements for the patients that we work with. This is where I live and work, and this is Killearn. This is the Killearn Health Centre that I work with my practice team, and we've got a population that we serve of just under 5,000 in Killearn and the neighbouring villages. And just down the road is the Glengoyne Distillery, which is nestling at the foot of the Campsie Hills, so that's where the important local whisky is made. And
is that one?
It's that one, yes.
That one?
It comes in bigger bottles as well. And also, just a couple of minutes away is Loch Lomond. And Loch Lomond is one of our most beautiful parts of the country. It's one of our main tourist areas. So if you do come to Scotland, and I hope you come to visit, as it's one of the places that you need to come and see. I can't promise the skies will be quite as blue as they are in these pictures. So Scotland, we've obviously got quite busy cities as well. The architecture is quite impressive within our cities, but we do have significant problems. And I was hearing yesterday about the health inequalities and social deprivation that people were describing in New Zealand around about the rural areas. Probably most of our social deprivation and poverty and inequalities happens within our inner cities, and we also have significant issues around lifestyle, particularly around alcohol misuse. So probably a bit rich, they're just showing you the picture of our lovely distillery. On a positive level, our government are trying to address that and improve the health of the population of Scotland through a number of strategies and initiatives. We've got an overall quality strategy which is based on the 6 dimensions of quality from the Institute of Health Improvement. And we're particularly focusing on safe and effective and person-centred care. And that's supported by national initiatives like the Scottish Patient Safety Programme, but also local initiatives at health board level. And it's probably the quality improvement things that are happening within my own board in Forth Valley that I'm going to talk most about this afternoon. There's also a recognition, as there is here, that our current model of care isn't going to be fit for practice, and we need to develop models of care that are more sustainable for the future, particularly in dealing with our ageing population. And the Scottish Government has a 2020 vision, although 2020 is getting ever closer, about helping to support people live healthier lives at home or in a homely setting. And that does require us to develop more robust primary care and community-based infrastructure so that we can manage people more independently in the community and certainly on a 24/7 basis. And to achieve that, we also recognise that we need to join our system together a bit more effectively. We have done quite a lot of work around primary and secondary care and trying to improve the interface between primary and secondary care in the last 5 to 10 years, and that's been quite successful, and we're trying to consolidate that. But we particularly need now, I think, to engage with other partners with social care services and the voluntary sector, and of course patients and carers and the general public. And there has been legislation introduced in the last year to try to integrate health and social care services more effectively, and I'll talk about that later. So Scotland and New Zealand, I think we do face similar challenges. We've not got the biggest populations in the world. We have a population of 5.3 million patients. Healthcare and the resources to support healthcare are one of the main things that are devolved from the UK Government to the Scottish Parliament. And like yourselves, we have a number of geographically aligned boards to deliver services that are appropriate to individual populations and provision of primary care services and secondary care services, and also care from independent contractors like GPs and dentists, optometrists and pharmacists. Quite a big workforce, 160,000 workforce within the National Health Service in Scotland. That doesn't include social care services, which would more than double that workforce. One of the interesting differences is that all services, all healthcare services in the NHS in Scotland are free at the point of contact, and that includes prescriptions and it includes GP appointments, out of hours contacts. One of the areas that I think we potentially could exploit more, and I think it is good to have services that are developed locally, but we do need to share ideas more effectively. We've got 14 health boards and we have some regional, national working, but I think there's an opportunity for us to share our ideas rather than everybody duplicating work within boards. And similarly, I think there's an opportunity for us to learn from other healthcare systems and to learn about what's gone well. And there's certainly some take-home messages that I've got from coming here. If we were going to learn things from New Zealand and Scotland, one of the things that I would like to do is to try to learn how we can improve some of our sporting results. And these aren't the worst ones, actually. So, I was going to focus on looking at how we engage with professionals, with clinicians, around quality improvement and effective use of resources, and actually how we take forward and join up our system. And it doesn't mean that professionals and clinicians don't need to sort of know the detail of strategy and legislation. That's not what captures people's hearts and minds. It's much more basic things than that, but it's often the basic things that we forget to do when we're trying to engage with people. It's about communicating, it's about being clear and communicating on the right level, and also giving people an insight into what the evidence is and the rationale for making changes, giving people the right information, and again, as we've heard several times over the last couple of days, it's about using data intelligently. But importantly, to allow people to engage with the process, we need to give people time. We need to give people protected time to think. We need to give people headroom, or we end up with pictures like this. We've got professionals dealing with multiple priorities, minds cluttered, unable to think about innovative solutions, unable to take forward practical suggestions and actually engage with the process and take that leap of faith forward. The other thing I think we need to think about when we're trying to engage with professionals at the beginning is actually to give people enough context, so they're not just working within their own part of the system. And I think it's about understanding the challenges that we face within our wider system, understanding the challenges that we currently face, and making people aware of the trends and the way things are going to go tomorrow, and also understanding what our model of care is. Because I think we all understand the challenges and issues we have within our own profession, or within our own team, or within our own part of the organisation, but we need to have that broader perspective where we recognise that everybody is busy and everybody has got capacity problems and everybody faces challenges. We need to manage professional expectations that we have of each other, but we also need to try to manage public expectations that are often driven politically. And certainly our public expectations are something that is increasing exponentially at the moment. We need to understand what we mean by capability, and often when we think about capability we think of all the wonderful technical things that we can do and all the things that have been developed over the last 10 to 20 years, and these are incredibly important, but actually it needs to be more basic than that. We need to think about where our skills are. Do we use our workforce effectively? Have we got the right people in the right places across our system? Because we have real capacity issues within our system, and I gather that there are sort of strains in parts of the system here as well. But we have significant capacity issues, largely because of the ageing population, also because of the economic situation. We have a significant issue with professionals migrating, and I was led to believe that they'd all come to New Zealand and they'd come and take some back. But it seems that you have similar problems with lack of GPs, particularly, but we also have a lack of nurses in the community. So our demographic challenge, I think the population projections are quite similar between Scotland and New Zealand. It's estimated that our population will grow by about 12.5%, but of course that's a disproportionate growth, and what we're going to get is we're going to get increasing growth in our older population, and actually probably a slimming down of the population that's within our workforce, which makes the challenge a bit more difficult. Currently, in 2015, 1 in 6 of our population are aged over 65 and 1 in 14 are aged over 75. And it's estimated that that will change, and by 2035 we'll have a quarter of our population, 1 in 4, over the age of 65 and 1 in 8 over 75. So quite a change, and of course as we get older we're more likely to become unwell, and particularly we will have an increasing prevalence of long-term conditions. And what that graph shows is the increasing prevalence of long-term conditions for stroke, diabetes, coronary heart disease over the next 20 years, but we could add in similar projections around dementia, cancer, heart failure, osteoarthritis, all these things we've got to look forward to. And that they will all increase over the next 20 years, and not and as people get one long-term condition, then we're more likely to get more than one long-term condition. So we have an increasing population with more complex needs. Yet, often our disease pathways tend to be around single disease rather than looking at holistic care and the needs of people with more than one condition. From a health inequalities point of view, this is also important because people who are living in the more deprived areas, certainly in Scotland, tend to develop long-term conditions and complex care needs 10 years earlier than their peers who live in the more affluent areas. So trying to give our professionals a bit of context around why we need to change and also understanding what we do just now. And this is a tiered model of care, and it's quite similar to the one that you've used in New Zealand, and it is based on different stages of the patient's journey. It just helps people to understand what services we put in place, how we deploy our workforce, looking at the interfaces and interdependencies between how we deliver our services for the well population, how we focus on prevention when people develop symptoms, as they develop long-term conditions and more complex needs, and also around end-of-life care. And I think what's important is that people's care needs will vary at different parts of their journey, particularly if they have complex care needs or long-term conditions. Their needs, they won't move linearly through the pyramid. It's about accessing services according to need, with the main driver being to try to provide services in the community. One of the issues that we also have to recognise is that our current model of care is quite acute focused, it's quite traditional. So we put a lot of resources into making sure that our acute services work, and we manage and resource our emergency department patient flows, referral management to the hospital and acute admissions. And that's resourced well, but it does tend to focus on crisis-driven care rather than preventative care. So we tend to be constantly firefighting, whereas we need to turn the whole thing on its head. And I was pleased to see that the model you used yesterday did actually turn things on its head, because I think we do need to focus more on positive lifestyle interventions and prevention, and managing long-term conditions and multiple morbidities more effectively in the community, and to look at developing a robust and resilient community infrastructure where we have got a capable workforce with capacity, where we have premises that allow us to work collaboratively and deliver different services to patients, or extended services to patients in the community. And we also have an IT infrastructure that allows us to communicate effectively with each other and to use technology to work with patients as well. And we also need to look at more proactive intensive case management or anticipatory care planning in the community for our more frail population, and actually try to avoid hospital admission unless it's absolutely necessary. So a lot of the work that we've been taking forward over the last sort of 10, 15 years or so has actually been quite successful in moving long-term conditions management out into the community. And I was going to mention the work that we've done around diabetes care. About 15, 20 years ago, we managed all our diabetics in the community, but they also attended hospital clinics, so we were duplicating a huge amount of work. And we recognised that that was not practical, it didn't really make sense. What we had to do some upskilling of our primary care workforce, and in particular we provided our practice nurses with additional training. So the focus now in the community is on evidence-based practice, on supporting self-management and preventing complications, and we're managing all type 2 and the vast majority of type 1 diabetics in the community. And that's supported by national initiatives like the GP contract and a national collaborative around long-term conditions. It's really important, though, that we don't just work in our primary care silo. It's important to have that interface with specialist services, so as we have a decent dialogue about patients with the most complex needs. There has been a bit of a flaw in the plan, though, and it's around capacity, because we shifted all the work out into the community, and we've continued to take over diabetic care and other long-term conditions management, but we didn't actually provide the community with any additional resource, either funding or additional workforce resource. And that becomes more of an issue that we need to address as the prevalence of diabetes particularly goes up, and it also suggests that we're probably not focusing enough of our thought on the lowest model of the pyramid and thinking about prevention and focusing on managing obesity and getting people to exercise more. So when we're thinking about how we take things forward with our professionals, I think it's about giving people that context of some of the challenges that we all face, and also sort of making sure that people are aware that the solutions lie with us and they don't need to be complicated. The current system isn't sustainable, but actually what we need to do is we need to work together to sort it out. We need to have clarity, we need to have a common purpose, we need to engage with people, but importantly, we need to develop good clinical leadership. We need to have clinical leaders that have got credibility with their professional teams and also will engage with the organisation to influence strategy. And it's also important that the change agenda doesn't sit just to the side. It's something that needs to be mainstreamed with the way that we work, and it needs to be aligned with our contracts and with our job plans. So we're going to try to give some examples of what we've done around whole system working in Forth Valley in Scotland, around quality improvement, around some of the work we've done to try to improve patient safety, making sure that we use our resources well, and looking at the processes that we've taken forward around care pathway development and looking at our more vulnerable patients. I think if we're trying to get engagement, there's a couple of cardinal rules though. I think what people need to do is people need to have time, they need to be able to reflect, they need to be informed, they need to learn, they don't need to be drowned in paperwork. And communication is really important, but it has to be communication that is clear, and we don't want a lot of strategic talk. We don't want to baffle everybody with jargon and pepper everything with acronyms that everybody is trying to spend their time trying to work out what it means. So it is about trying to be clear with people. So we have set this whole systems working project in place. We started this in 2009 in Forth Valley to try to engage professionals with quality improvement. We initially started it thinking that we would be focusing on engaging with GPs to help GPs see the wider system, but actually recognised was that we needed to do more than that. It was an opportunity to work in a much broader way, in a multi-professional way with primary care, but also to engage other parts of the system with the work. And that's what we've done. And the methodology is fairly straightforward. It's the things I mentioned before. It's about giving people information and the evidence about key issues. And it's identifying what the key priorities are for each year. It's not trying to do too much and to do everything at the one time, but doing everything in enough detail to get enough improvement. And in a way that encourages people to learn and reflect. And it's allowing individuals to make appropriately informed changes to their clinical behaviour. So as I said, we use data, and we give people comparative data. We have, for example, we have 56 practices, 253 GPs. We've had no problem with getting agreement from the GPs that we use non-anonymised comparative data, so anybody can see information to put things into context from any practice across Forth Valley. We give people evidence around best model practice, and we give them some protected learning time to do the work. What we've also got to remember is that clinicians, professionals are busy people, and they also tend to like structure. So we have to make sure that we have things planned, we communicate effectively, and that people are clear what the aims of the project are, what the timeline is, and what the work plan is. It's also really important if we're developing, for example, if we're redesigning pathways, that we involve professionals who are involved in each stage of the pathway, because it's wrong to sort of develop a pathway in one part of the system that's then got unintended consequences and additional workload to other parts of the system. So we give people practice profile data that highlights the prioritised work and allows people to put things into context. And there's 3 tiers really to the work. We ask individuals to reflect on the data, to consider doing some audit, to look at what their learning needs are, to look at what we're also doing well, because actually it's actually about learning from other people's good practice, and then bringing people together as extended practice teams to discuss again, the areas that we're focusing on, what we're doing well, what could be done better at primary care level, but actually what other things could be improved on in the system, and then bringing people together on an area-wide basis to really hone in on what the priorities are and to get a consensus. And it's actually the consensus of opinion that's actually quite powerful when we're dealing with the wider organisation. So it's about improving integrated work, developing that whole system perspective, and also encouraging development of consistent practice and using our resources effectively and efficiently, and trying to reduce wasteful variation. I think it's also an opportunity to get that balance within the system and to raise the profile of community-based services with our organisation, and recognise the huge skill set that there is out there in the community, the capability that there is within primary care, and what primary care actually contributes. And that's part of getting that two-way dialogue with the health board, but also with secondary care. And it also gives an empowerment, a feeling of professional ownership. I think what's really important if we're trying to maintain engagement, though, is to ensure that we continue to communicate and we continue to feedback, and the work needs to be outcomes focused, and if there are recommendations for change, they need to feature in an action plan and people get feedback around that. And a lot of the stuff that's come out from practices and from other professionals working in this has informed a lot of the remodelling that we've taken forward for 2020 and integration. So we've looked at a lot of work streams, and I'm not going to go through all of them in detail. I'll give some examples. Over the last 6 years, a lot of the work's been focused on the interface between primary care and secondary care, some on using our resources effectively, and also looking at how we can work more collaboratively and effectively in the community through things like locality planning and taking forward anticipatory care. I was just going to show a couple of slides that illustrate the sort of data that we give to people to help support the work. It's important to give contextual data as well as giving people information around their clinical activity. And we also need to remember that it's actually, we're giving people the guidelines as well as the comparative data. It's accessible to everybody through our intranet, which is on everybody's desktop, and through the general practice site, and people can access the data and the supporting information with a couple of clicks. So we can see our own practice data and all other practices within Forth Valley. Our own practice is highlighted in red, or the practice you're looking at is highlighted in red, neighbouring practices in yellow, and all other practices in blue. Giving people contextual data around demographics and the age profile, around the socio-economic breakdown of the practice populations, around the prevalence of long-term conditions, and then looking at clinical activity, looking at referrals to a range of specialties. And there is a suggestion that if you tend to be outlying in your clinical activities at that end of the graph, then it may be because of demographics or prevalence, but it may be something that people need to consider further. If we're doing some focused work and we're focusing, say, on cardiology services, then we will try and tie up the work so that people are looking at their referrals to cardiology as well as their admissions with people with heart problems. So we're looking at admissions, and more recently we're also looking at admissions per age group, because the people that we're wanting to keep out of hospital are our elderly population. So I suppose the outcomes from this way of working, I've sort of tried to group them into 5 main areas around informing future models of care, and that's having influence over the direction of travel from the health board, around improving our interface with other parts of the system, around developing integrated care pathways, around trying to reduce avoidable hospital admissions, and that's the sort of stuff that we can quantify as is how we're using our resources. And there is an element of power to doing this sort of work with professionals, because I'm talking about sort of 200 odd GPs in Forth Valley, but the last area-wide sessions that we held for this and to take this work forward involved over 400 professionals, a lot of who were GPs, but we also had a lot of nurses, allied health professionals, pharmacists, people from secondary care, people from mental health services, older people services. And actually, if you've got a consensus of people saying to the health board, this is what your professional workforce feel needs to change, then it's quite hard, I would think, to resist that. So it's a way of highlighting where people see the weaknesses in the system, where the gaps are, where the workforce pressures are, and actually it's a way of helping us to develop a primary care infrastructure that's more robust. And people are coming forward suggesting ways that we can work in partnership with social care, and it's an opportunity to highlight the issues that we have around IT and making sure that we use technology intelligently to improve the care of our patients and keep people safe in the community. We have done a lot of work with secondary care, and actually a lot of the pathway work has involved our secondary care colleagues in developing pathways, and there are a lot of offshoots and benefits to this kind of work. We now have information evenings and following up in project work between primary care and secondary care, and these are well attended. We have processes in place to look at significant events that happen across the interface, recognising the element of risk that happens when people go into hospital or transferred out of hospital. And we also have a process in place for developing pathways so that we develop them in a whole system way. And there's another thing that's I suppose quite important to us is actually making sure that GPs and consultants network and give each other time to talk and to discuss individual cases. And when we started this work, we actually found that really slid down the agenda as a priority because everybody seemed to be quite busy. But actually, I think through taking the work forward, people realise that that's quite an important thing for us to be doing. Developing integrated care pathways, we've looked at these across a range of specialties, and I was going to mention the dementia one, which we've talked about previously. I think when we looked at our dementia pathway, we did that for a variety of reasons, recognising the challenges of our increasing prevalence of dementia. We also have a new dementia strategy in Scotland, and we recognised there was a lot of inconsistent practice, both in primary care and in specialist services, and we also weren't particularly well joined up between health and social care. So when we looked at the pathway, there was a lot of areas that we needed to look at developing in a more consistent way. And we've taken forward, and it was about people's roles and responsibilities, so we've taken forward work around what should be done pre-referral in primary care, what our criteria are for referring into specialist services, learning around the use of cognitive assessment tools. We didn't have an electronic referral pathway, so mental health services are a bit of an outlier for that, so we developed one. And there were similar inconsistencies within our specialist teams, and we also clarified what the preferred process was for shared care and ongoing management after people had been diagnosed with dementia. And we have put in a workforce to help us to navigate the system more effectively. There were specific learning needs as well around legal and ethical issues. And there was a lot of learning, I think, for primary care around power of attorney and having the confidence to have these discussions with families. Other things around adults with incapacity, end-of-life care, and it was also our opportunity to reinforce some of our work around anticipatory care planning. And of course, all that work doesn't get done within 6 months to a year. We need to consolidate it. So there's ongoing work and improvement work that's led by a series of subgroups and steering groups. Hospital admissions, challenge for us, particularly for the elderly. We don't want old people to be admitted to hospital unless it's absolutely essential, because they quickly lose their independence, they become institutionalised, they lose their rehab potential. We have I think our challenge in Scotland is that, like all boards in Scotland, we have a steadily rising number of admissions, but what really messes our system up as well is that it's really hard to get people out of hospital once they're in hospital. So it's important for us to try to not put people into hospital. We have the lowest number of beds that have been occupied by patients with long-term conditions in Scotland, so I suppose that's quite reassuring. And we also have the lowest rate of emergency admissions, although there is a creep up. We particularly focused on trying to keep the frail elderly out of hospital, and we can demonstrate that we've got a significantly reduced number of admissions from care homes. And a lot of the work that's come out of the professional input from this type of work is around the development of ambulatory options to admission, like rapid access clinics, the development of a frailty unit and hospital at home models. And that also means that we're also changing people's mindsets and changing things from a culture where the default position when somebody becomes acutely unwell is they get admitted to hospital. And the fifth and final area is around how we use our resources effectively. And this is actually really quite important, because for every pound that's spent in general practice, we have the influence of how 7 other pounds are spent across the healthcare system, particularly around acute admissions, around referrals, around prescribing, around diagnostics, and around the use of the emergency department. We did some work with diagnostic services, which was apparently considered quite innovative, but it's probably innovative because diagnostic services are often the forgotten partner when we tend to put pathways together. And it was about making sure that the right person got the right investigation. And what we realised was that there was an awful lot of inconsistent practice. There were pathways in some places, but actually the pathways weren't being particularly well adhered to. In some cases we didn't have pathways, and investigations were just being carried out. There were actually some safety issues as well, and we did wonder whether we were using our resources wisely. So we looked at some tests, and we looked at radiology services and lab tests, at some tests where it was felt there was limited value added. And we recognised, for example, if most people getting a lumbar spine x-ray, the value of that didn't really add to the patient journey. We created a new access pathway so that the people that still needed lumbar spine x-rays would get them, but actually the number of lumbar spine x-rays has reduced by 50%, and that's by giving people information and giving people the right data. CT of head was another area that we looked at, and there were safety issues around this because CT of heads actually involves a lot of radiation. It's equivalent to 100 chest x-rays. And a lot of people were getting a CT of head who probably shouldn't have been getting a CT of head. And by introducing a guideline and by giving people the information about radiation doses, we also have reduced our CT of heads by almost 60%. And similarly with lab tests, there was huge variation, and we looked at the areas where there was a lot of variation and duplication of testing. Where there were national guidelines, we put them in, but we also developed our own guidelines, and there was a significant reduction in the test areas that we looked at. And then there was prescribing. Now, this graph highlights the prescribing costs for all health boards in Scotland. And so it's the cost per patient. We were the jaggy purple line at the top. And what we recognised about 3 or 4 years ago was we were about £30 adrift of the Scottish average, which is this yellow triangular line going along. And it wasn't because our clinical outcomes were any better, it just was that we were actually spending quite a lot on expensive drugs with no additional evidence attached to them. So we developed a prescribing strategy, and we focused on certain areas of high cost. And in actual fact, over the next 3 years, our prescribing costs came out and they're just below the Scottish average now, which is a different trend from the other health boards in Scotland. And I suppose the importance of that is it also saved £9 million on a recurrent basis to the health board. Because prescriptions are free in Scotland, but actually they cost the health board obviously and the government, and we've got a primary care prescribing budget of about 65 million, and we managed to make £9 million savings. I think the behavioural changes is shown particularly if you look at the areas that we've had a focus on, and we spent loads of money on lipid lowering drugs, and this was one drug that we were spending over £1 million on in a year. So clearly the pharmaceutical reps had done a really good job on the GPs, but when we gave people the data and the information for change, you can see that things moved pretty quickly down. It's not just about money, it's also about quality and safety. We also implemented antimicrobial guidelines, and as a result, our broad spectrum antibiotic prescribing in primary care has reduced by half. And we're now looking at through the patient safety programme, looking at other unsafe medicines combinations and polypharmacy reviews. So I was going to move on to, so that's a lot of the work that we've done between primary care and secondary care, and looking at how we use our resources effectively. What we need to do is we need to look at how we can build up our community infrastructure as well, and can we use this kind of methodology of working with professionals to develop that. to make sure that people can live longer and healthier lives at home or in a homely setting. And recognising that we have a huge range of services in the community, and how do we get people to work together, and how do we make that infrastructure more resilient and robust? And how do we make sure that we manage people with long-term conditions and multiple morbidities more independently in the community? And how do we work with patients and carers more effectively and see patients and carers as partners? We tend to be quite paternalistic, and we give care to people rather than actually working with patients and carers as partners in defining their care. And this is something that we're trying to take forward. We also have got integration around health and social care, and we've got legislation that's come out which is snappily titled the Public Bodies Joint Work in Scotland Act 2014, which means nothing to nobody. So how do you make something like that real, relevant, meaningful to professionals, to busy professionals working at ground level? And how do we see that that's going to improve the care for patients? And we're trying to do that through localities. And again, it's looking at individual communities and looking at clinical leadership. And what we've done is we've divided our area of Forth Valley, we've got a population of 315,000, into 6 clinically led localities. And each locality is led by a GP, along with a nurse lead, an allied health professional lead, somebody from pharmacies, somebody from older people services, somebody from mental health services, and somebody from social care services and the voluntary sector. And coordinating an action plan and determining what the priorities are for each locality. But giving the wider group of professionals protected time to communicate within localities and to network and to collaborate. And I think the hook for professionals in this is, while all this strategic melee is going on around legislation, actually we can be a bit of ahead of the game, and we can highlight what our priorities are, and they can be there at the forefront of health and social care development. One of the challenges we have, and it's important to get some quick wins in this situation to try to make sure that we get engagement, is that strategic change really does take quite a while to happen, and pace and change can be a bit of a disengager. And I think we need to communicate in an honest way with professionals around this, but it does also take a while to establish networks, and for us to get together and determine what our priorities are and to flesh these out and to develop an action plan. But it is important to deliver improvements and outcomes. And we've used this model to try to help people visualise what we mean by locality working. And it's a person-centred model. I think that's the most important thing, is that the individual is at the centre of the model. It's about holistic care, and it's about whole system working. It's also the individual supported by their immediate network in the community, by their carers, and also by a core locality network of a range of professionals working more effectively in collaboration to provide services, with an extended locality network, of a team of professionals for people with more complex needs, and of course there's an interface between community-based services and secondary care and tertiary care. I think the key drivers within the diagram, as well as it being person-centred, is it's about developing clear, integrated care pathways and taking forward anticipatory care planning, being proactive and not waiting for the crisis to happen. And importantly, we need to remember it's about the individual. We tend to be talking about professionals working together in professional interactions, but we need to remember that at each stage of the locality model, it's about a series of interactions with the individual by professionals. And that slide took me ages to make, so it's going to appear in every presentation I do for the next 5 years. So I was going to finish off by talking about anticipatory care planning and what that really means, because it means different things in different systems in different countries. It's different from advanced care planning we tend to talk about in the UK as around end-of-life care. Anticipatory care planning is more about managing people with complex needs, and it's about proactive intensive case management, probably for the 5 to 6% of patients who use up 75 to 80% of our health and social care resources. So it's for our most vulnerable. It's for the people who are most at risk of hospital admission. It needs to be person-centred. It's the individual's anticipatory care plan. It's not mine. It's not the nurses. It's not the social care services plan. It's the individual's. And it is about working with the individual and their carer, if that's appropriate, to develop the type of care that they feel is most appropriate to them. It's also about improving people's awareness and health literacy, so that people are more aware of what their healthcare options are and what the likely outcomes are. It's also about quality of life. A lot of it's about clinical need, but a lot of it is about what would make your life good. Now that might be around their health, but it might actually be it's important to see people. I want to go out to the hairdressers, I want to go out for a coffee, I want to go out to the bowling, and we need to enable that as well. So that's about working with the voluntary sector and social care services as well. And this is a cultural change. It's a cultural change for our population, but also for our professionals as well. And also we need to sort of build this into our capacity, because it takes time to do this properly and to manage people in a holistic way, and actually to listen to what people want. We're quite fortunate that we can share this information across the system to a degree anyway. And we have an electronic anticipatory care plan that summarises the patient's anticipatory care plan. Patients should hold a copy of that, but we can put the information on a computer system that's hosted by the GP practices, and that can be shared with out of our services, with the emergency department, and the ambulance service in the front door of the hospital. We would like to get it switched on to more places. It needs to be shared with social care services, and it needs to be used in the wards to facilitate discharge planning. But professionals have engaged, and Forth Valley have engaged really well with this way of working. We set ourselves a target that we would, for the first year of doing this, that we would try and get anticipatory care plans in place, measured through the key information summary for 3% of our population by the end of March this year. And in actual fact, we're at 4.5% of the population, because people see that it makes sense. It's not a prescriptive process, but we try to facilitate it for people by giving people triggers. It often depends on professional judgment. We ask people to get to have an anticipatory care plan if they have a significant problem, like a diagnosis of dementia, or if they have a palliative care need. But we also need to remember that the most vulnerable people are the elderly, who are living alone and who are housebound. And we also need to look at people who are moving chaotically across the system as well. I was going to finish off this bit by talking about a couple of patient stories, and this is a lady that I mentioned at the seminar on Tuesday as well for the first one. And Margaret's an 84-year-old patient of mine. She's recently been diagnosed with dementia, but she's got a fair number of other health problems. Her main carer is her daughter, and she lives nearby. And Margaret was admitted twice in the last 12 months, once by herself and once by our services, and on both occasions she had gone off her feet. She was quite confused, she was really fatigued, she was falling, and we were concerned that she'd had a stroke. But in fact, she had a stroke, she had a urinary tract infection, and she developed a delirium as a result of that. And because of all the drugs that she was on, she had a low sodium, which was just complicating the issue. So we didn't want Margaret bouncing back into hospital, so we offered to develop an anticipatory care plan with Margaret and her daughter. And it was an opportunity for us to highlight on the key information summary that if Margaret became unwell, not to whisk her into hospital, but to think about whether she might have a urinary tract infection and she might be delirious, and to treat that as appropriate, and that can be treated in the community. We also sorted out her drugs, and for once actually stopped some drugs, and sorted out her low sodium. And we discussed our patients with anticipatory care plans, or those who have just been discharged from hospital, at our practice meetings. And it was an opportunity to raise awareness of Margaret's situation, but we also recognised that there was learning needs within our team around recognition and management of delirium, and we dealt with that. We also continued to support Margaret and helped her daughter to put a power of attorney in place, recognising that she's vulnerable living alone. We've got a mobile personal alarm that she wears, and because she and her family are more informed, they know how to recognise any deterioration in her condition quickly, and we've got emergency antibiotics that can be used in the house. So we're working with them in partnership. Second lady I was going to mention is a much younger lady, Laura, and we probably developed an anticipatory care plan with Laura before the term anticipatory care plan was coined. And Laura sadly passed away at the end of last year, and Laura had rapidly progressive multiple sclerosis. She was a single parent with twin boys, and her main carer was her mum, and her mum didn't live with her but lived fairly nearby. And Laura, as she became disabled, increasingly disabled, she recognised that there was a chance that she might require long-term care, but that wasn't what she wanted. She wanted to stay at home and spend as much time at home with her family and friends. And it was a challenge because her home wasn't particularly suitable, so we looked at her home environment and helped make adaptations. We used technology to try to maintain safety and independence, and dealt with a whole range of clinical and medicines issues. We also had to remember that there were the childcare issues, and we also had to think about carer support as well. However, it can be done, and it was done by really good coordinated work with a lot of people putting in a lot of effort. And I think what was important is that Laura was cared for the next 8 years without any unplanned admissions at home, and any unplanned admissions, she was cared for at home, and she also died at home, which was what she wanted. So I suppose my summary slide is, I suppose, in recognition that we have had a huge amount of engagement from a lot of professionals across Forth Valley. I think we need to maintain that clinical engagement, and I think the way that we need to ensure that is through continued communication, making sure that we feed back to people, and also addressing recurrent themes. And also there needs to be a recognition that professionals are influencing new models of care. It's also really important to grow new clinical leaders and have clinical leaders that have credibility within the profession and can also influence strategic change. And you get the organisation and different parts of the organisation working to a common purpose. And it's about giving professionals the ability and the power to change the system. And it is good to talk, but importantly, it's good to have the time to talk. And I did manage to get somebody that was successful in sport in Scotland. And as well as talking, it's important that we also listen to each other. So, a bit of a challenge. Thank you very much for listening to me. Thank you.
Thank you, Stuart. Hey, I'm on. You might have finished with an anticipatory care plan, and that was very informative as well. But in fact, if I was to use that as an analogy, it might also be your whole structure, your whole approach to your presentation was very much anticipatory. If I think about it, you gave us a view of the future about the population, about the disease demands, and quite clearly we need to do something about that. You need to do something about that in Scotland. Your population profiling is probably no different from a lot of others, but you've demonstrated there that the change is required. You explained why. You said that we should be thinking whole of sector and bring the clinicians with us. And then you provided us with some examples about the various integration activities and other examples that you had. I like your must-dos: avoid excess paperwork and use the right communications. And as you said there, that's not rocket science, which is just as well, because there's not one rocket scientist out there. Health professionals, not rocket scientists. You provided the outcomes, and that's really important that we know that we're measuring something. We're actually demonstrating that what we're doing has an impact because if we're not doing that measurement, if we're not sensing and recording, then it's probably futile. There's no reason to continue on. I did notice that you use a person-centered model, and Chiquita, I haven't seen you use that yet. I presume we'll see it. It was very busy. It's a lovely set of pictures, and everyone in the PHO, you'll get to see that for the next year or two, I'm sure. But if I were to cast one other comment here, probably from all of you, didn't that sound pretty consistent with what we're trying to do here? So, you know, we've been following Forth Valley for a while, and this has really been quite a bit of our leadership. You know, you have been, and Forth Valley have been a lot of our pointing the way to the future. And so what we're doing here was very closely behind what you're doing there. And it's great to see that doesn't matter if we're on the other side of the world, we can think the same way and use the findings that you've got. And even further, that you are looking now at the new challenge, which we need to look at as the new challenge, which is, so if we've got some success in primary and secondary, how do we start to build on those successes and start to introduce, or we have better integration with our community services and our social services? You've got that. We'll be very interested in watching how that works, because as soon as we find out how you do it, we can do it here. So once again, Stuart, thank you very much for your presentation today, and I'd like everyone just to thank you once again. Thank you,